All right, everyone. I think we're going to get started again. So if everyone could direct their attention back up front. Good afternoon. My name is Mark Garevich. I chair the Department of Population Health at NYU School of Medicine, and I'm a member of the Roundtable and pleased to have the opportunity to moderate this session. We are really at a nice spot in the arc of the day, I think, where we've sort of thought big picture about the issues, focused in on some really amazing work happening in two specific places, and now get to begin to pan back out and really think, well, how can we generalize that? And what are some of the barriers or policy issues that are really at their core standing in the way of or requiring deeper attention to really take this work to the next level. And so we're going to hear from four speakers around issues like measurement, legal concerns, payment, and equity. And I'm going to briefly introduce the speakers and then give the floor over to them. So Rochelle Davis is President and CEO of the Healthy Schools Campaign and co-chair of the National Collaborative for Education and Health. Denise Chrysler directs the Network for Public Health Law's Middle States region, which is located at the University of Michigan School of Public Health. Kelly Hall is the founder and president of the Pembroke Policy Consulting, a national health policy firm. And Kent McGuire directs the education program at the William and Flora Hewlett Foundation. So we will begin hearing from Rochelle Davis. Welcome.
So I've been asked to talk about the practice and potential for the health sector to use education metrics to better align the health and education sector to support children's health. In my time today, I'm going to first introduce you to Healthy Schools Campaign, share what we've done in this space and why we think this issue is so important. And then I'm going to talk about findings and recommendations, as well as highlighting a current opportunity for the health sector to align metrics with the education sector. Healthy Schools Campaign advocates for policies and practices that support schools in creating the conditions of student health and school wellness so that all students are in school healthy and ready to learn. We want to leverage the power of school health to address the growing health and academic disparities that exist in this country. We see school health as core to the education sector's mission of preparing young people to be productive adults. School health is about supporting the mental and physical needs of students, of providing a supportive and healthy environment, and teaching students how to be healthy. These are all critical elements to preparing young people to be productive adults. We take a policy and systems level approach to change and see this work on metrics and data sharing as critical to long-term sustainable change. Healthy Schools Campaign works at a local level in schools and communities across Chicago to empower parents, principals, teachers, and others to integrate health and wellness into every aspect of the school experience. We have taken lessons learned from this work to address policies and system-level barriers at a district, community, state, and national level. We recognize the importance of integrating health metrics into the education accountability system through our work in Chicago. In 2010, we were working with about 30 schools to meet the requirements of the USDA's Healthier U.S. School Challenge. It's a recognition program for promoting healthy classroom management, healthy birthday celebrations, non-food rewards, physical activity breaks, etc. One of the barriers that we kept coming across was that schools were focused on measures that were part of their publicly available school report cards and did not want to take on any project that did not help them meet the items in that report card. And so we asked the district to include a metric about the Healthier U.S. School Challenge on the report card. And of course, we were so pleased that they put it right on the top in big, bold yes or no. And the response to this was pretty immediate. Within 2 years, over 300 schools met the Healthier U.S. School Challenge. This change of practice was the groundwork for future policy work, and CPS is one of the strongest health wellness policies in the country. It led to the establishment, the hiring of a chief health officer for the first time, and the creating of the Office of Student Health and Wellness. We paid attention to this experience, and integrating health metrics into education accountability structures became a big focus of our work. At the national level, we were very fortunate to partner with Trust for America's Health, first with Jeff Levy and now with John Arbuck, both members of this roundtable. You know how smart they are, so I do not need to tell you how impactful it has been to work with them. Working with TIFA and others, we brought the issue of incorporating health metrics into education accountability systems to a broader audience for discussion and deliberation. Through the National Collaborative on Education and Health, we convened a metrics working group. We engaged with educators, data experts, and others to better understand the education metric landscape. One of the key conclusions was to focus on chronic absenteeism. Now, we've already heard a lot of discussion about chronic absenteeism, so I'm going to skip most of what I thought I was going to need to say. I do want to add one additional point that I don't think was made. Chronic absenteeism is designed to track the time that a student is not in the classroom. Unlike traditional attendance data, chronic absenteeism includes excused, unexcused, and suspensions. Chuck's presentation reaffirmed the conclusion that we reached about seeing chronic absenteeism as the best proxy metric for how a school supports student health and school wellness. The measure of chronic absenteeism is getting more traction within the education sector. The U.S. Department of Education Office of Civil Rights now collects chronic absenteeism data every other year that becomes publicly available. We also see under the new education law, ESSA, that chronic absenteeism is a requirement on every school report card, and that will happen for the first time this fall. And finally, 36 states and the District of Columbia have incorporated at some level chronic absenteeism into their state accountability systems. So our principals that wanted to focus on the report cards, now chronic absenteeism is on those report cards and in those accountability system. Now, I'm going to come back to that a little later when I talk about new opportunities for aligning health and education metrics. Through our work, particularly supporting 50 state teams of health and education state staff and others to expand Medicaid-funded school health services, we really developed a better understanding of the role that education metrics could play in advancing the goals of the health sectors. We clearly heard examples today that confirm the importance of metrics and data sharing across sectors. As the health sector has focused more on prevention, population health, and care coordination, as well as looking more closely at the social determinants of health, the issue of education metrics has generated more attention. So to supplement the knowledge gained from our own experience and that of our partners, we commissioned Resolve to conduct in-depth interviews on the specific question of how is the health sector using education metrics. These interviews confirm and enhanced our understanding of the field. The draft report is included in your meeting packet. So what have we learned? So we have seen that education metrics are being used by the health sector, and that at the end of today is not news. But the most common usage that we have seen is attendance, high school graduation, kindergarten readiness, third grade reading, and measures of teacher wellness and turnover. These metrics are used more often for surveillance and prevention and less often to support individual student outcomes. We continue to see and hear about the barriers, but there is a strong understanding of the potential that data alignment between the sectors has for improving outcomes, so the interest in this topic is high. I'm going to highlight 3 key barriers that we have found in our work and some kind of upstream recommendations to make this work hopefully easier to happen at the state and local level. So first, data sharing. We certainly have found and heard that the HIPAA and FERPA are perceived barriers, and the next speaker is going to focus on that issue. That health systems invest heavily in data security and are often concerned about linkages with less secured systems and systems interoperability. So we think that to make, again, this easier for everyone, there needs to be stronger guidance on not just the interplay between HIPAA and FERPA, but also the overlay with state privacy laws, because that adds an additional complication in many places. And then we heard today a lot of areas of innovation, and those need more visibility, more discussion, and more sharing. I think the next topic is messaging and training, and Heidi briefly referenced, I think you called figuring out the crosstalk was your phrase. And so we certainly have heard that again, time and time again, that there's an important need for both educators and health professionals to understand one another's sector and speak in a common language. To overcome the current barriers around language, philosophy, and lack of training by both education and health in one another's disciplines, we recommend the following: that colleges of education, schools of public health, and medical schools begin to collaborate to promote the use of a common language and to support guidance and training on how health and education can talk to one another. I think it's the last area that I am going to address is needs assessment and evaluation. So the joint use of data to document, monitor, and evaluate the delivery of school health services is critical, but rarely done, and that health systems are not evaluated based on their patients' academic outcomes. We certainly heard today that in places where other measures get incorporated, it does change the conversation. So our recommendations are that the following areas really need more exploration: how different sectors document unmet student needs, how strategies to share data to improve delivery of care, and exploring strategies to evaluate program impact. So I want to end my presentation with what we see as an important new opportunity to bring health and education sector into more alignment through shared metrics. The Every Student Succeed Act, commonly referred to as ESSA or ESSA, the acronym gets pronounced differently, is the new education policy that was passed in 2015 and is now just being implemented. The federal government's entry into education started 50 years ago as a civil rights measure. There was already some mention today that in this country, education is much more of a state and a local concern. But the federal government did see it was important to get involved in order to achieve equity. As discussed, health disparities impact education disparities, so leveraging the power of school health to support equity is an often overlooked area. Now, our national education policy is based on 3 layers of accountability: between the federal government and the states, between the states and the school district, and between school districts and their communities. So the current administration is taking a very hands-off approach to trying to achieve equity, so that accountability structure is not very strong at this moment. The accountability structure between states and school districts is based on a set of standards that schools need to meet. They are then allowed to use federal resources to do needs assessment and implement programs and evaluations to help them meet the state's accountability measures. The new opportunity is that under ESSA, states were able to go beyond just test scores. 36 states, as I mentioned, in the District of Columbia have chosen some measure relating to chronic absenteeism. This opens up the possibility of states including health measures in their needs assessment and allowing school districts to use federal funding to reduce chronic absenteeism. We have developed guidance for states to help them think about how to incorporate health into their needs assessment, and that was also in your briefing materials. And we're starting to look at how how the federal policy defines evidence-based interventions and to help identify health interventions that fit that definition so that that information is readily available to states and school districts when they get to that stage. Now, in the accountability structure between school districts and their communities, chronic absenteeism will be on every publicly reported school report card this fall. This provides the opportunity for the broader community, including those in the health sector, to understand what is happening in the school and create a new engagement point. Of course, there are plenty of challenges. In the 36 states in the District of Columbia that have included chronic absenteeism in their accountability measure, they're actually weighed relatively low, from 5% to 20% of a school's score. So it's still there, but we should just understand how it really still fits into the evaluation framework. And we actually are now seeing states seek to redefine the definition of what is a student, what is a school day, and what is being absent in a way that could totally mask and undercut any of these new metrics. So obviously something that we in attendance work are looking at very, very carefully. So in Chicago, and I think that, just to say, Jennifer and Heidi have already figured out that chronic absenteeism is a great metric to bring the health and education sector together. In Chicago, we're working with Advocate Health System to develop a new school service delivery model with 4 schools around the shared goal of reducing chronic absenteeism. Advocate concluded that the chronically absent students in the schools near their hospitals are the same children who show up in their emergency room. And this alignment of goals has created a very different framework for the school and the hospital to work together. I want to also mention that next month we will be releasing a report on why the health sector should use chronic absenteeism as a metric, as a way of highlighting this opportunity. Our experience, confirmed by these recent set of interviews, reveals that institutional support for shared metrics and data system is still relatively new. Many of our presenters today are truly innovators and are breaking new ground that is critical for system-level and sustainable change to meet the needs of children. I'm very pleased to have been invited today and am excited to have been part of this important conversation, and I look forward to working with all of you to support schools so that students are in school healthy and ready to learn. Thank you.
Thank you, Rochelle. Denise.